Hello, my dear friends. I'm Dr. Vaishaly Bharambe, Professor Anatomy. I've been teaching anatomy for more than 25 years, and today I'm going to talk about the 6th cranial nerve. It's short and sweet, but clinically relevant lecture. Come, let's begin. It's also called as the abducent nerve. So now you can see here a whole lot of theory about what are the topics under which you should cover a cranial nerve. Please pause the video, read this. But I'm going to teach it. Okay, this is only for you when you're writing your own answers. Let's introduce the cranial nerve as one of the three important nerves which give motor supply to the muscles of your eyeball. What are the other two? The third nerve and the fourth nerve. This nerve is also called the abducent nerve. What is its attachment to the brain? It's externally attached to the pons and medulla at the pontomedullary junction. So where does it take origin from? Now students, you must be thinking, didn't you just tell me? It doesn't work that way. Origin for any cranial nerve is deep origin as in nuclear and then external origin. And the nuclear origin is very important because that is the only way you will understand how the nerve actually got formed. Come, I'll teach that to you. So divide the origin into deep, nuclear, and superficial external attachment to the brainstem, which I'm sure you are able to see when you see the brain. Right. So abducent nerve actually takes origin in close to the deepest part of the pons, very close to the floor of fourth ventricle. It lies deep to the 7th cranial nerve. You must be thinking it's difficult to imagine. Of course, it's difficult to imagine. And that is why we always use images to understand neuroanatomy. Okay, so abducent nerve gives supply to the lateral rectus muscle of eyeball and therefore gets classified as general somatic efferent. Let's keep that in mind and let's try and get this into our brain in the form of an image. Now what you're seeing here is a section of the pons. You can see the basilar part, you can see the tegmental part. You can see that this is the floor of fourth ventricle and this here is the motor nucleus of 7th cranial nerve. If you remember, I just told you abducent nerve nucleus lies deep to the 7th nerve. So here, this red colored thing is your 6th nerve nucleus. Of course, it's not red in real life. This is only so that you are able to visualize it. So what is a nucleus? A nucleus is a collection of neuronal bodies. Okay, so there will be dendrites and there will be axons. The axons will carry information from the nucleus forwards. So the axons of this nucleus travel forwards as shown, emerging out of the pons and medulla at the pontomedullary junction to travel forwards towards your eyeball. Okay, that is the learning we need to take from this. So where are the dendrites? The dendrites are spread out because they will receive information from your cortex. You will understand this a little better soon. So deep origin done. We now come to superficial origin. So this is your pons, this is your medulla, and here at the pontomedullary junction between the pyramid and the pons, you will be able to see the origin of abducent nerve as it exits from the brainstem. Okay, as it is passing through the pons, it will pass through medial lemniscus, trapezoid body and basilar pons. So, what have we studied? We've studied all of this and now we want to talk about its course and distribution. It's a very short and sweet nerve, okay? But how do we understand the course? See, your books will give you a lot of theories. I have also put up a lot of theory. Pause the video and read it. But to really understand, use images. Come. So here you are seeing a section of pons. Okay. You can see the nerve, nucleus, nerve passing through the pons and emerging out, passing upwards, forwards, laterally. Please use your hands at this stage. Upwards, forwards and laterally. Okay. That's the course of the nerve. As it reaches the apex of petrous temporal bone, to enter into the cavernous sinus, running along the floor of cavernous sinus, along with which artery? Along with the internal carotid artery. Then traveling on to the superior orbital fissure through the ring of Zinn, as you can see here, and then emerging out to supply the lateral rectus muscle, LR6. LR6. So, this is an image of the cavernous sinus. Can you see that it's related to 4 cranial nerves laterally? This is your internal carotid artery, and here, below the cavernous sinus, running inferolateral to the internal carotid, is your abducent nerve. So, 4 nerves on the lateral side of cavernous sinus, one passing deep to it, and that one passing deep to it is your abducent nerve. Okay, friends, if you're liking this lecture, then do please like, share, and subscribe to my channel. Remember, this is the only way I can understand if my lectures are really helping you. I will feel encouraged to make more of these videos. Please also share your comments in the comment section and of course your doubts as well. I'll revert back to you as soon as possible. Now, hit that bell icon and let's continue with the lecture. Right, so we'll do this once more and I'm confident that you will know the course very well. First, let's imagine there is a section of Pons as seen here. The abducent nerve takes origin from the nucleus, travels forwards, upwards and laterally. Reaches the apex of petrous temporal where it turns. It reaches apex, turns. Why does it turn? To pass deep to the cavernous sinus, along with which artery? Internal carotid artery. Now it reaches the superior orbital fissure to pass through the ring of Zinn, to enter inside the orbit. In the orbit, what does it supply? It supplies the lateral rectus. And that is why we say LR6. Okay, so we've got the course of abducent nerve. Origin, course, it is supplied the muscle. Some peculiarities have to be discussed because they are so clinically relevant. So what are these? The nerve bends downwards from Pons, upwards along the clivus. Okay. And the nerve bends so sharply at the petrous temporal bone that whenever there's an increase in the intracranial pressure, the brain gets slightly displaced downwards. Can you imagine that? You have CSF and the rise in the pressure pushes the brain downwards. When the brain gets pushed down, your abducent nerve gets pushed down too, but it's anchored at the petrous temporal, because of which it gets stretched. So, this very long winding course, okay, as it enters into cavernous sinus is something we need to really remember. Okay, we need to remember this. Let's understand why we need to remember it. Question: what is the importance of the fact that abducent nerve bends sharply over the petrous temporal bone as it travels into the cavernous sinus? What is the importance? The answer here is that whenever there is raised intracranial tension, the brain is displaced downwards. Abducent is very, very vulnerable at this stage and it gets pulled. As it gets pulled, it is unable to supply the lateral rectus. Now your mind should start thinking, okay? It's not able to supply lateral rectus. So your LR is now paralyzed. If your LR is paralyzed, what will the medial rectus do? Medial rectus will overact. So you will have a patient coming to you with other symptoms and a medially deviated eyeball. That's very interesting because that is something that is very obvious to you immediately. And it should immediately make you think of abducent nerve palsy. Okay? So, question very often asked in the Bible, what is the relation of internal carotid artery and abducent nerve? Before we go forward, can you answer that? See if you can answer it. Inferolateral. The abducent lies inferolateral to the internal carotid artery. Both of them lie deep to the cavernous sinus. Right. So now this abducent nerve, who is instructing it to make your lateral rectus act? It receives its instructions from the cerebral cortex. Okay, so corticonuclear fibers will be stimulating your abducent nerve to cause your lateral rectus to contract. Parallelly, it is also having connections to the medial longitudinal fasciculus and to the fibers from superior colliculus through tectobulbar tract. Now, what is this? Why are we discussing it? there's a very beautiful idea behind why we are discussing it. Understand. This is your vestibular nerve nucleus. Okay. Remember, vestibular balance. Vestibular balance. Okay. So now this vestibular nerve gives rise to, nerve nucleus gives rise to fibers that travel up and down along the brainstem, connecting the third nerve, fourth nerve, sixth nerve. What are third, fourth, sixth? They are all the muscles that supply the muscle. They're all the nerves that supply the muscles of eyeball. Also connecting the facial nerve nucleus. What is facial nerve? A nerve that supplies muscles of your face. Also connecting hypoglossal and connecting the motor nuclei of your cervical spinal cord. Now we come to the reason why medial longitudinal fasciculus, this bundle, is important. This bundle, which is connecting all these nuclei, is the reason why when you turn your head, okay, I'm turning my head towards something, my body is able to balance. My neck is not flopping here and there as I turn somewhere. Okay, my neck, my face turns, maintaining balance towards looking at some object. Parallelly, all the three nerves which are supplying the muscles of my eyeball are maintaining the balance of my eyeball. My eyeballs are not going like a cartoon in various directions. They're all uniformly turning towards that one object to which I want to look, maintaining coordinated eye movements and the balance. So that is why MLB, or medial longitudinal fasciculus / bundle, matters. See, it's so beautiful, but you have to understand it. You have to enjoy it. Then you're never going to forget this tract. Now, from this one discussion, you've understood that MLB will also have to connect with third nerve and fourth nerve, because three of them, third, fourth, sixth, are together moving your eyeball. All three have to be connected if the eyeball movements have to be coordinated and balanced. Parallelly, my face cannot remain bland. When I'm looking at something, my face gives a parallel smooth expression. Which nerve? Facial nerve. So that's how tracts are logical. Right. Parallelly, also remember the tectospinal tract and tectobulbar tract, which is also connected to abducent, will help in the audio-visual body movements. You hear a sound, your eyes turn, your body also turns. All that is that tectobulbar tract. More about this in some other lecture. Okay, so your abducent nerve is receiving information from cortex, connected to MLB, connected to tectobulbar, and giving efferents to LR, lateral rectus muscle. Clear? Okay. So now here is a man who's come to us with right side eye medially rotated. What should you think? Yes, you should think that there is some kind of raised intracranial tension or cerebral issue which is causing his abducent to get stretched. Okay, and that's why the LR is not acting. So medial rectus is overacting. Okay, so it's a common lesion which results out of raised ICT. It can also occur because of cavernous sinus thrombosis, because abducent is passing deep to it. Internal carotid aneurysm, because internal carotid is traveling along with it. And also some vascular lesions of Pons. Presentation, similar. Okay, medial rectus overacting. That side eye is medially rotated. So I hope you enjoyed this short and sweet lecture, and I'll see you in my next lecture on cranial nerve.